Good morning, everyone. Thank you for coming. Lovely to meet old friends, and I don't mean that in a derogatory way. People I've known for many years, and for new friends, I hope to meet. It's lovely to meet you in London, and I want to just discuss things with you. Kind of a personal journey. There's always a danger when, as a dentist, you've got nothing on your hands, and you think, what can I write about? This came about. I was at a conference in Brazil, and it was a very interesting conference because all the Brazilian postgrads spoke in English to get them used to going to the US to present and so on. And their English was first class. Their research was first class as well. And one of the other keynote speakers was on molar incisor hypomineralization. And we were chatting, and the night before she was going to give a presentation, and we had a discussion about hypersensitivity to sensitivity, and she used the term dentine hypersensitivity on in MIH. And I challenged her on that, and I'll come on to that. And I think that kind of upset her. The next morning, when she gave a presentation, she explained how much she had to change her lecture because of what I've said. I didn't mean to do that, but that's what often happens. So I wrote a paper on this, and it's a personal view. Now, first of all, I have to say, don't pretend that you know everything. And when you go outside your sphere of knowledge, you rely on other people. So some of the things I may say may not necessarily agree with some things that you would say if you were in that specialty, but just bear with me as I kind of outline my philosophy. Thank you. You all may know Mr. Bean. It is a very interesting cartoons on his toothache, and on the right hand there, you see that this was a person who extracted his own teeth because he couldn't get it to a dentist in the United Kingdom. I don't advise that. So basically, and you have this in the abstract, there are several aims that I want to present, and I hope I will get through them on the time that we have. But just to outline the problems that clinicians have when we try and diagnose conditions, particularly those with similar pain symptoms. And the more I looked into this, and I looked into various selected categories of pains, I found there's a lot of controversy and disagreement about the terminology. And at one point, I wished I never went into it because it became quite challenging. And I hope if I have time to give some recommendations when we describe it. Again, I'll reiterate this, that we're looking at the problems that clinicians may have. And basically, as I've just said, the terminology and definitions is confusing. And from a diagnostic perspective, precise terminology are important if we are going to be consistent with our diagnosis in resolving our patients' dental pain. I would say, however, that human beings like everything in boxes. And unfortunately, dental pain and dental conditions and symptoms are not in boxes. So we've got to be very careful of being dogmatic. We need to be pragmatic. Now, this isn't a question about semantics, and I hope that it will help you in your diagnosis. If you look at oral med, I said that there's disagreement and confusion in their current classification, and I hope to address that in the presentation. If we look at the complexity of problems of diagnosing pain, this is from an umbrella review of systematic reviews, and looking at head pain or facial pain. most prevalent types of pain worldwide, encompassing cranial, oral, and facial pain. And again, they gave prevalence of pain in adults, different groups, 1.1, so for burning mouth syndrome, to 80% of cancer-related oral facial pain. Children, it ranges very small for TMJ, osteoarthritis, to 83 for all types of headaches. And again, the theme that's going to come out in the lecture, I hope, is this problem of lack of standardized language, terminology, classification among specialist groups, and it hinders diagnostic agreement and impedes comprehensive research. And establishing a widely accepted classification would facilitate both communication and terminology. Now, it's interesting that for dentists, toothache is the most common condition that we will see in our lifetime. Now, what often happens is that if you get certain groups looking at certain things in oral med, they will come up with certain conditions. If you go to a dental practice, you have a different picture. So please be aware of that variation. But I went to actually look at definitions of toothache, and you would have thought that it would be quite precise. And in the Merriam-Webster dictionary, pain is in or about a tooth. And we get odontalgia, an ache localized in and around the tooth, which to my mind is very vague when you think we spend most of our time looking at toothache. Now, if you're looking at signs and symptoms, now, for those of you who know, if you have chronic pain, they use the McGill pain questionnaire, and you would have a lot of things like sharp and lancinating. I don't know, the average person in the street would understand the difference between lacerating and lacerating, but these are the words that they use. And to be fair, it works very well with chronic pain. This is the first in the UK for those of you interested in veterinary medicine. This is a poor sloth in Chester Zoo, which is north of London, and they had a problem. They extracted or looked out. I think they did some endodontics eventually, clean out the abscess. But very often we find that extraction is the end point in our treatment, which is very sad. Don't get political, but people were talking earlier about the NHS in the UK. The NHS, National Health Service, is not what it used to be. And we're finding that patients, for various reasons, are extracting their own teeth. Again, I wouldn't recommend you using pliers to extract your teeth. Or if you do, please sterilize them first. Now, if we look at the definition of toothache from our point of view, we used to talk about reversible and irreversible pulpitis. And we know from historic classic work that there's very little correlation sometimes between what we see in the mouth and what you see in histology. Now, we rely heavily on our instrumentation sometimes, but some of them we've got to be very careful. And there's a terminology in English language which is let sleeping dogs lie. And sometimes we can be a bit too presumptuous in going ahead and doing things. And I like this definition recently, well, not recently, from the endodontist. It may have updated, but I believe looking at the program, someone's going to speak about symptomatic irreversible pulpitis. So again, we look at reversible, symptomatic, irreversible, and asymptomatic. And you know, that may be a better way of looking at things. I remember many years ago, an orthodontist said to me, he did the test and his tooth was non-vital. He said, would you mind doing an endo on it? So I redid the tests, everything, and it was non-vital. And I did an access cavity, and guess what? The pulp was waving at me. It was perfectly vital. So we shouldn't just rely on instruments are an aid, radiographs and so on, but sometimes we need common sense. Some of you might know C.S. Lewis, who wrote The Lion, the Witch, and the Wardrobe, and he wrote this: if only this toothache would go away, I could write another chapter on the problem of pain. It can pain, toothache can be very depressing. Studies by Pao et al. Indicated that some individuals could almost be driven to depression and suicide if it continues and continues and continues. If you look at the medical side, sometimes someone has just come out of an operation, they're heavily loaded with medication, which doesn't work the pain, they can't sleep for days and days and days. If you ask them the name or time of the day, they can't remember. Sometimes we forget the impact of pain. The other thing I would say, although it's not, we often see visible, if you like, disabilities, but there are patients, and I'm sure someone will bring this up, there are invisible disabilities, invisible pain, which we don't always encounter. And sometimes people don't express the pain in the way that we would want them to. In the old days, the British males were very stoic. Now that the men cry, but in the old days, if you had a problem, you kept what was called a stiff upper lip. But that doesn't seem to apply these days. Let's see if this works. If not, no, it doesn't work. That was on Burns Night, Robert Burns' poem about the ode to a toothache, and what it would say was how terrible it was, and it kept him up for a year, and it was like the most unimaginable pain he'd ever had, worse than the ravages of hell. A very descriptive poem. This one I always thought was quite interesting for children. I wouldn't recommend this again, but simply the obsession of dentists of extracting teeth wherever they look at, and if you look at the last bit, I still have 12 to go. Oops, that's the wrong one, I confess. But what's one crocodile's tooth, more or less? Then suddenly jaws went snap, and the dentist was gone right off the map, and he went one, could only guess, to north, south, east or west. He left no forwarding address. But what's one dentist, more or less? If you go to Brazil, there's an awful lot of dentists there. So let's go back to terminology very quickly. The classic terminology which I started on was this Mark Nadi 1985, dentine hypersensitive can be defined, pain derived from exposed dentine in response to chemical, thermal, tactile or osmotic stimuli, which cannot be explained as arising from other dental defects or pathology. The pathology was changed to disease, being more appropriate. It is essentially a definition of exclusion. So from a practical point of view, you're going to spend a lot longer in the diagnostic procedure trying to find whether you include it as a diagnosis and not include it. Other terms are used are cervical dentine sensitivity, hypersensitivity, tooth sensitive, and more recently for the periodontist, root sensitivity, prevalence between 10 and 30. Now, very quickly, the problem with the root sensitivity is that periodontists are obsessed with plaque. And they said, well, plaque was an etiological cause of dentine hypersensitivity, but it's quite clearly not, because historically, dentine hypersensitivity was a condition of like people who clean their mouths and not neglect their mouths. And when I did studies years ago, is that if you took the plaque from the buccals or facial surfaces, there was very little plaque, but sensitivity. If you then recorded the plaque on the lingual or tongue side, there's a lot of plaque, but no sensitivity. I'll leave you to ponder that. Patients generally complain that pain is rapid in onset, sharp in character, and short in duration. It's an exaggerated response of the normal cold denting, and the patient is often only aware of the problem when external stimuli is used, such as cold. One of the problems often is that the patient comes in to see you, you give them, ask them to rinse out with cold water, and they go, ouch, it's going, immediately you've got sensitivity. You've got to be very careful about that, because what you have to realise is that you need a good history. When I used to recruit for clinical studies, people would come in and say, oh, you've got sensitivity, but when you actually evaluated them, they didn't, and vice versa. So just be very careful. And the key thing is, it's transient nature, and once you remove the stimulus, there's no longer any discomfort. According to postgraduate student myself, patients present a variety of orofacial conditions, complex in nature, and require at times specialist service. And again, you know, neuromuscular, vascular, and persistent idiopathic facial pain. So again, going back to what I said earlier, depending where you do your examination, if you're in if you're like a pain clinic or a med, you'll get different types of patients because they are referred to you. Many years ago, when we were doing the studies on periodontology for dentine or root sensitivity, we saw over 500 patients, which are 50 patients, and looked at them clinically. So we did a questionnaire and then clinical exam. And we had a very high percentage of patients with dentine or root sensitivity. And so when we wrote the paper, everyone quoted it, saying that there's more root sensitivity higher in periodontal patients with either due to the treatment or through periodontal disease. But as I pointed out, if you had a cancer service, you would have referred patients with potential cancer to come to your hospital. The likelihood you would have a higher prevalence in that hospital than you would have in the average practice. So again, we've got to be very careful when we look at the literature. So if you look at other studies, orofacial pain affects about 9 to 10% to 16%, and women are more affected than men, and that seems to concur with a number of studies. They keep on changing the terminology. So when as you see, I graduated in '77, we had different terminology, atypical facial pain, for example. Now they change it again. There's persistent facial and oral pain, varying presentations lasting more than 3 months in the absence of clinical neurological defect. That's from International Headache Society Classification 2020. Atypical odontology, you might have used that term. Again, International Association for the Study of Pain, they define it as a severe throbbing pain without any major pathology, and maybe a pain of dental origin without any definitive organic cause. The Israeli group wrote a persistent dental over pain. And again, there's no gold standard here. And existing ones are not sufficient or reliable for diagnosis because the physiopathology is not well defined. And again, this is the interesting thing, that its diagnosis is often by exclusion of all other conditions. Now, what often happens is that women over a certain age, mid-50s, have had a lot of endodontic treatment, they've had teeth extracted, but they still have the pain. And what happens is that more teeth are extracted, in some cases even more invasive material, but this pain is still there. A friend of mine he went to see a dentist who said, oh, you had pain, we extract the wisdom tooth, one wisdom tooth. She still had the pain, went back, and she pleaded to take the the upper wisdom tooth up and persuaded to take them. I think she had 3 teeth taken out initially, and she still had the pain. And eventually she was sent to a local hospital. They couldn't find any cause. They did a number of scans, and they were starting, I think, amitriptyline. And I haven't asked her recently, but for years she was on amitriptyline, but she still has the pain. So what's going on? I used to say to my students, who actually worked in the clinics many years ago, I said, if you don't have a definitive diagnosis, don't dive in and do the treatment. John Cannon is
Sir, a stupid dentist went on, and then total extraction.
Yeah.
Was it?
Yeah.
Finishing.
You use the word stupid. I wouldn't dare, but anyway. Again, this is another definition of atypical odontogia. But again, there is continual disagreement on the taxonomy and diagnostic criteria. So it makes it very difficult for both dentistry and medicine. And we need to work with our medical colleagues in all conditions. And I know a colleague is going to talk about that later. We all like to talk about financial burden. This was a paper, one of these dental media papers, but you can see that they estimated, yes, it's quite an old paper, £3,000 per patient every year, and the amount of time that is lost for atypical facial pain. It says on the right hand side, you know, the areas of location. But toothache and oral facial pains has a burden on the economy. If we briefly look at molar incisor hypomodalization, you know, for those of you who are in pediatric dentistry, the cause of it, and it's their developmental enamel defects in children. It represents a significant challenge in pediatric dentistry, particularly with behavior, and it's increasing all the time. But look, it says it's characterized by discolored, soft enamel that is prone to post-eruptive breakdown, hypersensitivity, and increased risk of curious lesions. So essentially, it's a condition which is completely dissimilar with dentin hypersensitivity, and that's the problem with the diagnosis. Again, they disagree with a standardized diagnostic criteria. I'm involved as a kind of participant in the looking at guidelines getting to the pediatric. They let a periodontist in to look at pain, and there's still no agreement, which everyone. And the problem is, if you look at every group, whether it's periodontists, pain specialists, they discuss things in their own group. So you have guidelines in their own group. You really wish that everyone's got together and had a common workshop which resolves everything. Yeah. So we as clinicians can be on a better standing. This is very quickly the guideline, you know, take a picture you would see in MIH, and you've got various treatment philosophies. And I'll leave that there for you. Being a dentist or a doctor is about observation. Can you see the number of animals in the background? For those of you who can't, perhaps you should see Specsavers, Vision Express. Often people count all the animals in the background, and they confidently say to me 8, 9, but they forget the eagle in the middle. I don't know if you ever saw the video about the gorilla in the room, and they were playing basketball, and they were going around, and during the whole session, the background was being changed. The gorilla came in and did his antics, and people didn't recognize the gorilla. Sometimes when we're diagnosing, we have in our own mind immediately, oh, this is the problem, we'll sort it. It may not be the problem. So again, we've got to be very, very careful. These are 6 cases. This would be a lecture on itself, which I'm not going to. But basically, these are the type of problems that we would face, both dentally and oral med-wise. And it is a problem how to diagnose this. Again, the key thing with diagnosis, you identify the problem, diagnosis, differential line, and you measure the problem. And it is an art. So again, taking density time sensitivity terminology as a guide, but it should apply to all conditions. The key thing is that in density time sensitivity, you have to eliminate every conflicting condition. You might remember mnemonics when I gave a lecture in Brazil. I asked them about Socrates, and the younger ones didn't know a football player called Socrates. Because I showed a picture when he didn't have his beard, and they didn't know who he was. But we often use things like mnemonics, like Socrates and Kate. And what I find is that you try to remember what the mnemonic says rather than what it does. Some of you might remember the very old one about learning the cranial nerves. And one which we used, I can still remember, but I've got the note here, on old Olympus towering tops, the Finn and German viewed a hop. And it gives you the 12. And again, you take time. Now, it doesn't tell anything about the characteristic of the nerve. So one person then wrote, some say money matters, but my brother says big brains matter most. And that gives you the type of nerve. Is it sensory or is it motor? But I think you can go further, and if you look at development, it doesn't tell anything about the development of the cranial nerves. So, we should ask questions. Now, I have to say at this stage is that you can do these type of questions quite easily in an hour, 2 hours in a hospital clinic. If you're in a busy practice, in the old days, I could treat 30 plus patients and the NHS can't do it now for various reasons. You got 15 minutes. So you rely on a good history, and sometimes, although it's not, it wouldn't be exactly, sometimes you rely on your experience and what's going on. It seems that they don't like you to have experience and what the old-fashioned term gut experience. Yeah. But if you know your patient, there's a difference between having a patient who comes regularly to your practice and someone who comes in off the street. There's a big difference in diagnosis. So these are the type of pain questions you could ask. Some cases, patients either want to tell you or they don't know. So you have to be patient. Assessment of pain. I mentioned the McGill's. There are other questionnaires. Some use a visual analog scale, but that doesn't really take into account the impact of the pain on your day-to-day living. So this scale actually includes, the impact of your day. Can you do the activities with your discomfort? And that's very useful for medical as well. Now, going back to the type of questions you could ask, if you're in a hurry, if you like, you could ask 4 questions. By the way, these are adverts. I think I said that this is Power Rangers, if you can remember, in black and white. For the older ones in colour, they come back again. And this is supposed to be resembling pain relief for headaches. And this one here, Michael J. Fox in Back to the Future, it's an advert for diarrhea. Don't ask me why they use it, but it's interesting. So it's important for us to acknowledge that the definition of sensitive is a diagnosis of exclusion, and it encourages clinicians to exclude other potential causes for the patient pain, both dental and non-dental. Again, observation, can you spot the figure, which is different? You've got 1 second. If you have, you're a genius. If you take 10 minutes, I think you have a problem. But sometimes we miss things, don't we? We miss things. If you go the third row up from the bottom, you might find something. Now, from a clinical point of view, these are the differential diagnostic items that you would look at. Again, they will all take time. They are both dental and non-dental. So you will use special tests. If you ask an endodontist, they would use endofrost and things like that, ethyl chloride. But when you're doing study for dentine hypersensitivity, you wouldn't necessarily use that. Now, again, looking at classification, just be careful, but this is from an oral med colleague of mine, and he's relating the different types of conditions. Again, he uses the term reversible, pulpitis, neuroreversible. And again, we've looked at that with us changing in definitions there. And it gives you an idea. This is then a memoir. But looking specifically at dentine hypersensitivity and atypical odontologia, persistent dential pain. Both conditions of exclusion, there are a complete difference with the how you would treat it. So again, looking at various conditions, the key thing to look at is it similar to dentine hypersensitivity? If so, what type of pain is it? Remembering if it's from any other dental or non-dental condition or disease, then it's not dentine hypersensitivity. Take home message, I hope I'm never give up, ever give up in your diagnostic attempts to find a solution. You will find that diagnostics is not easy. It's a changing service. In one exam, we had an oral med lady, lovely old man, used to come every year when the final year students used to actually treat a patient on their final day. They don't do it now because patients often didn't turn up. And during the day, she changed her diagnosis. So the poor undergrads in the morning got a different history to the ones that in the afternoon. And that caused a bit of a problem. But they passed, don't worry. So, take-home message, differential diagnosis of dental pain may conflict with an accurate diagnosis. The key thing really is a good medical and dental history and a thorough clinical examination with any supplementary diagnostic tests. Be aware as causes of non-dental pain, and if in doubt, excuse me, if in doubt, refer to our oral med colleagues. I wish we had joined up services sometime. You know, very often it's very difficult to get information from medical colleagues, particularly in practice, unless you work in a clinic, joint clinic. I used to work in a clinic and I did pediatric dentists, so the community dentists, and the medical people often refer their patients to me and vice versa. This is on the diagnosis of oral facial pain, again challenging. The theme keeps coming back, the problems with the terminology. We recognize how difficult it is. You need to have a framework, an algorithm or whatever to determine an accurate diagnosis. Again, a very careful history. The old adage, listen to the patient, they're telling you the problem is quite valid. Sometimes they don't, they lead you astray, but you have to use your common sense. Remember that for our purposes, the biggest problem is apart from periodontal disease, which is dental caries, toothache. The other things we see are fairly small, whereas if I was in normal med clinic, I would see a different type of presentation. And again, it's just explaining the types of pain you would get. Wide range of treatments are used, but early diagnosis. Reassurance is very interesting in companies. Now, don't just talk about factual testing. They talk about things like reassurance and confidence. For example, if you have a denture fixative, and every time you went to speak, if I had a denture, which I don't, my teeth fell out, I would lose my confidence and I wouldn't be reassured of their product. So you notice that a lot of the marketing now, they would say about confidence. Are you confident with their Now, there are some red flags, which were very rare, but there are conditions that you could come across, giant cell arthritis and so on. Now, we're not going to see that, but if you have any doubt, refer them to a multidisciplinary team. Be aware that both the terminology and definitions of the conditions are often confusing. From a diagnostic perspective, precision terminology are important if we are going to be consistent where our diagnosis results in the patient's pain. Again, observation. We often get cluttered by, what we see. A number of times when you get people to look at the gingiva and plaque, and you ask them, is it healthy? So, oh yes, healthy. There's stippling and the like. And I said, but the person's 50 or 60 years old. Where's the stippling? Can't you see the inflammation? They can't see it. Why? Because they're too cluttered with effects. So you look at that wall, and when you have a closer look, what do you see? Very good camouflage. That's why you use disclosing solution for a plaque. But sometimes just dry the two surfaces, you can see it. As you say, what happens when you do all this treatment and you still get the pain? You've either got the diagnosis wrong, or you quickly refer to a colleague who knows what's happening. Don't be ashamed of referring. I remember when I was in practice, I used to speak to my oral surgeon, and he said, "Don't worry," because I used to send any black spots and whatever discolored in the mouth. And I said, "I'm very sorry, because most of them I thought were benign, but that's not my problem. I'm not a specialist, and virtually all of them were, okay. But there could be a point in time when it's not okay." Okay, I think that's it. Thank you very much. Hope I understood my time. Thank you.